Hello, everyone, and welcome to this Pharmacy Times webcast on cancer care updates in the era of COVID-19. I'm Bhavesh Shah from Boston Medical Center, Senior Director of Hematology Oncology Pharmacy, and I'm joined by Dr. Ali McBride from the University of Arizona Cancer Center. Today, we're going to discuss a number of topics pertaining to the strategic management of cancer care through COVID-19 era. So recently, Ali, there was changes in the ASCO guidelines on cancer care, a lot of different changes, I think one being on the growth factor support. So I wanted to get your assessment on that and how that's impacted your practice.
No, I think that, with the alignment of what's happening with COVID, with the changes in our workflow, I think we've seen a lot of different organizations and also institutions really change their guidelines to highlight removing patients from being admitted into sensitive areas, which can increase COVID at this point in time. And one of those was actually the growth factor guidelines. NCCN came out with the information about how they've actually moved utilization for intermediate risk. That's our 10 to 20% risk for premature leukemia in that aspect where they actually use growth factor. So at that point in time, or before that, our guidelines were, if you're greater than 20% FN or you're within that 19%, use growth factor, less than 10%, don't use growth factor. But that intermediate risk was where every single institution and also payers had their own guidelines for utilization. And that's really been remarked on for the years. With COVID, that changed. ASCO also kind of worked with us on this too, really implement that statement saying, use growth factors earlier on in the intermediate growth factor risk patients. So what that has done is it's allowed our institutions to use growth factor, whether we're using, for example, a biosimilar in these cases, or brand name therapies, depending on what's happening there, and then actually maintaining that utilization throughout the course, and thus preventing, or hopefully preventing, febrile neutropenia patients being seen in ambulatory clinics and or leading to an ER or inpatient admission. So that guideline, which really kind of made the movement very early on, it's actually probably one of the best pieces that we've seen being remarked upon by an organization to influence payers. Hopefully has helped patients not get admitted, and also in many cases, not really worry about what's happening in regards to having a higher mass issue where they can have COVID transmission. So in that setting, we have seen this clear change in guidelines affect our populations in the outpatient cancer center setting, and thus increase utilization of growth factor for prevention of those patients. And that also has kind of earmarked what we're going to probably see over the next probably months is what did that do to our patients? So I think we have, what was happening and also what we had to do, but also we had to earmark these discussions and also relate to discussions with payers. And so the payers then also had to address that. And they actually responded very quickly in the setting of COVID. And that really has helped our patients. So not only have the guidelines affected us, the institutional guidelines as well, but also the payers have really jumped on board rather quickly to maintain that discussion. So I think this has been a clear change. In fact, I don't think we've heard enough about that. So I think this is a great discussion for many of our members and also our teams as well who are aware of this.
That's great. So your institution has adopted those guidelines in regards to increasing the threshold for getting patients onto growth factor support because of the NCCN guidelines and ASCO, and of course having payer buy into it also. The other recommendation that they have is about actually decreasing the frequency that the patient comes into the clinic. So can you talk about a little bit about how those changes have also kind of changed the practice specifically with growth factor support for the prevention of febrile neutropenia?
And so we've done a very different type of position here. We actually do most of our chemotherapy outpatient. In fact, a majority of our chemotherapy is not even done inpatient. So like our our high-dose, high-dose ARC, reinduction regimens, ifosfamide regimens, just to name a few. So most of it's done outpatient. What we've kind of done to reduce the actual number of patients coming into clinic is we've really kind of worked with telemedicine. And so patients will come in just for their chemo. We have a fast shot clinic for quick, injections for those as well to really minimize their time associated in clinic. And having those direct appointments also where patients come in, then you see a provider, they get their labs, they go directly into their infusion appointment. So having that mainstay of treatment has been essential, if not salient, to reduce those patients' risks. So that's been the first piece of that puzzle. The second piece really is the patients who are waiting for treatment or who are waiting for an appointment. How do we minimize those patients? And I think, something we'll probably be talking about a little bit more is telemedicine. And really with what's happening from a CMS standpoint, what's actually being addressed, for utilization has been important as well. However, going back to this discussion about growth factor, which is really where your discussion is moving forward to, it really has been utilizing, for example, same day. We use same day growth factor here for almost every single patient. And that really has minimized patients coming back the next day for treatment. This discussion has probably been around for many years, but we actually have that within our guidelines for policy. And also we even showing that there is no difference in terms of outcomes or safety. So it's really been a very interesting discussion to see how now this has actually been brought back to the limelight in regard to same day growth factor use.
Yeah, absolutely. I think the other aspect that I could add is that we've actually even actually trained our patients to self-administer or have their family caregiver to actually administer for them to avoid that second visit to the institution. And luckily we actually have a specialty pharmacy. So sometimes we actually even utilize our specialty pharmacy resources to have a travel nurse going to the patient's home to administer the growth factor support so the patient doesn't have to come back. And the other change that I can talk about from a payer perspective that I've seen where CMS actually came out pretty fast about making this change was in this public health emergency, they're actually allowing an institution to buy and bill a drug as it was actually being administered in the clinic, but it's actually being administered in the patient's home, as long as it's a supervised visit by a provider. And the institution can go and hire a nurse to go and administer into the patient's home. So it's pretty amazing how we've all come together to reduce the risk for our patients. So I think there's a lot going on with biosimilars, as you may know. Can you talk about some of the new biosimilars and how has kind of COVID impacted the biosimilar adoption strategy at your institution?
One of the things that we've seen, with COVID, without COVID, I think there's probably two different types of impacts there. I think with the growth factor utilization, just in terms of growth factor itself, we've truly adopted a large or quick onset. So for growth factors, pretty much everyone who actually comes in will get a biosimilar, just based on the cost and access issues. And really, when we're looking at that, we have to be concerned about patients, about their insurance. Maybe they don't have insurance because of the current issues with unemployment rising so dramatically, and so many of our patients being pulled off the payroll rolls. So we've been utilizing biosimilars rather quickly and adeptly. We've actually had those approved through our formulary. We also implement those actually on a case-by-case basis with patients, and quick uptake was seen with growth factor. Really, the only issue there is going to be dependent on the payer and what type of biosimilar they're using, or if they don't use a biosimilar, what's the brand name product they're using as well. So that's been actually done and implemented with our clinical team. Really, our clinical pharmacy team is making sure that's implemented across the board. With the therapeutic biosimilars, when it's coming to that, that's been a little bit more difficult. We have utilized or used uptake here for many of our therapeutic biosimilars. These are more of our oncology, for example, your bevacizumab, your actual rituximab, and also your trastuzumab in these settings. But we still, at this point, are having a lot of pushback, and that's coming from the payers. So we're doing a lot of work to make sure that patients have the correct access. Patient assistance forms are set up in case they have any changes. And we've seen great diligence by the payers as well, implement those kind of consistent policies for maintaining a lower copay for their patients. So really maintaining access and adherence. So I think from that standpoint, we've been very thorough in maintaining that level of care. But the issue that we have seen come up is going to be addressing with payers, and they may actually have different types of associated biosimilars they want to use. And that's actually led to some difficulties too. So we're still making sure the patients have access, really improving that patient consideration for cost, as well as adding that medication or patient assistance format too. But we're still having some problems. I think we're having roadblocks because we have so many different payers. You may actually be seeing that too, Bhavesh, in regards to what they prefer, or even actually addressing it with your own local, Medicaid or Medicare, where they haven't even put that on the formulary. So you're trying to save them money, right, as an organization and also as a member of the healthcare community. But unfortunately, it doesn't always pan out.
Yeah. No, I think, in such times, this is such an important topic. I mean, if you look at Medicare alone, they've spent $1.9 billion on COVID-related admissions. In Massachusetts, majority of the institutions are reporting out to be a total loss of about $5 billion in the past 2 months. So this plays a significant role, financial role, where it becomes so important to have a lower cost drug. So I think definitely it's an important aspect at this time of COVID pandemic. In regards to other strategies that you've utilized, I mean, I know you said payer roadblocks are probably one of those things that you guys are working through. Are there any other roadblocks in regards to adoption of biosimilars?
I think at this point there really isn't. I think there'll always be some questions depending on who's out there in regards to the physician prescribing. I think that's always going to be a question. But I think when we're looking at the type of biosimilar, we have seen definitely from Europe discussion on relapse refractory patients versus frontline therapy, where they had seen early on that utilizing a therapeutic like rituximab curative therapy, physicians were hesitant to actually switch. But if they're relapse refractory, there wasn't an issue in regards to that. I think in the US market, since we're still new to this, we're probably on par with Europe in regards to these therapeutic oncology biosimilars, because it's actually been recently approved there as well. So the biggest issue really has been, are we switching a patient? So are we considering that patient to be maintained on that biosimilar across the board or biologic agent, right? And we have seen some hesitancy. So, one of the process implementation pieces is we'll start new patients on the biosimilar. However, if the patients continue on the brand name drug, we'll just continue them on that as well. Because that's been a difficult conversation for many people. Well, why are you switching me now? What's the after effect of switching? We can talk about those switching studies early on. We can address that, but I think there's still some hesitancy, which is one of the reasons why education from the patient, caregiver, physician, healthcare provider, and team are always important. But really at this point, the implementation hasn't been as problematic. In fact, we've been switching almost all of our patients to the bevacizumab biosimilar. We're moving now into the other biosimilar areas as well, kind of a stepwise approach. But the issue that we're really seeing is some questions may come up with the patient. We're doing in-services for our nursing team and physician team, but it really is coming down to the payer index. So that payer roadblock, as I'm using, has really prevented us from switching. And that's been problematic because that just means, knowing your staff, you're working with a number of patients. You may see 300, 400, 500 patients in clinic a day, and you're adding to your multiple infusions as well as with your finance team. That creates a lot of workflow disruption. So if you actually put that in, you get that approved, well, all of a sudden everything else is approved versus that bevacizumab or that rituximab or that trastuzumab. Well, then you have to go back and then readdress with your finance team to re-implement or reapply for that, as well as change the medication assistance program, right? So I think there's a lot of workflow changes that are happening here. We're doing implementation rather quickly, and it hasn't been relegated to any subjugation by any of our team members, but really it's actually been one of the forefront issues with our finance team members.
Mm-hmm. No, absolutely. I think definitely we've actually been able to switch a lot of patients because we're lucky in Massachusetts where we've collaborated with a lot of the payers and have a great formulary approval for biosimilars. But I think the challenge is, of course, switching patients. There's this administrative burden, getting the prior authorization, getting the patient educated, getting the providers educated. So I think there's definitely a lot of work that's involved, and that kind of slows down the process. So I think we're on our third biosimilar change process right now. So hopefully that's the last one, for this year. But switching gears, in terms of your ambulatory oncology clinic, what type of, have you seen the shifts in volume? Have you guys seen changes in practice in terms of managing these patients differently because of COVID? Just wanted to get your input on that.
We've actually seen an increase in our clinic numbers, believe it or not. We have seen our infusions increase dramatically for our patients. We've seen a higher number of patients, unfortunately, especially coming from CancerCare. You don't want to see that, but we have seen those numbers increase. And that's been across the board for ambulatory section. Now, we're very fortunate here at our facility where we do outpatient chemotherapy for a number of therapies, right? So what do I mean by that? I mean, typical type of inpatient admissions, such as our ifosfamide regimens like AIM, ifosfatopricide, some of our SMILE regimens for lymphoma, most of our lymphoma regimens, for example, DHEP, ICE, you name it, we're doing it outpatient. Even our thiotepa, we use outpatient. So we've moved a lot of those patients, from, which are AML patients, which are lymphoma and also sarcoma, and another few types of regimens outpatient. So we've increased those numbers, right, which is really risk mitigated or decreased the risk for those patients to be in an inpatient setting. What we have done also is really utilize the combination of outpatient chemotherapy, which really transitioned to outpatient chemotherapy, with the addition of safety checks with telemedicine, right? Doing your tox checks under telemedicine, you don't need to come in. We've even removed some clinic visits as well. For example, we used to see patients who would get FOLFOX on days 1 and 14, days 1 and 15 in these cases. We'd see them every visit to really do the tox assessment. We've changed that, and we're utilizing those pieces of the puzzle to do telemedicine as well. But we're also even implementing, of a side note, certain pharmacogenomics, like for example, looking at UGT1A1 for your irinotecan, for all irinotecans, to decrease or mitigate side effect profiles if you have those recessive mutations. So really we're adapting some of the newer technologies much quicker. And I think with telemedicine, we saw telemedicine go from a hypothetical, well, I know we'll talk more about this too, a hypothetical discussion across the board for all of the US and only subjugated in rural areas, to now, this is now a mainstay. So in less than 6 months, we have adopted a workflow system which wasn't there before. So these tools have been critical. Our tox checks are ensuring patients have the appropriate factors and prevention and medications as well, and also minimization of risk while they're here, to ensure the patient actually gets the best care. And I think those are just some of the workflows for the patient, which we've adopted. And for the physicians, our prescribers, advanced practitioners, our pharmacy, we've even implemented the telemedicine pieces, transition of care management follow-up as well, utilizing that telemedicine piece, telehealth, or maybe we can phrase it, Bhavesh, tele-oncology. That will be our patent line for the next 20 years when we go up to
Absolutely.
CMS. So that, I think that's, those are some of the things that we've done. I know some of those aren't kind of outstanding. These aren't things that are new or novel. I think just bringing them together all in a workflow series within your oncology service line has been the actual big difference in that discussion.
Yeah. No, I think it's a great point, and we'll definitely talk about telemedicine more, because I think that's definitely the new care model that we have to adopt, especially in light of what we're seeing across the country with the second surge. And, so I don't think COVID's ever going away, and we need to adapt.
It's been a great conversation, Bhavesh. One of the things that we've seen is provisions, implementation, guideline developments that have been put in place at many institutions. So, what type of provisions have you put in place at your institution to combat or address the potential new complications of treatment during the COVID-19 pandemic? So, if you can maybe start off, like, what impact has this pandemic had on your cancer center, both from an inpatient perspective and outpatient perspective?
Absolutely. So I think, starting with inpatient, we don't have as many admissions related to oncology treatments. But as you had mentioned, cancer doesn't stop COVID. I think that we have to continue operations. Every single cancer center I've heard is they're actually like at same capacity that they were before. Their volume continues to grow. Obviously, the screening is down, but I think that we still have to maintain our patients and have new referrals, newly diagnosed patients that come through. So I think we just have to be extra cautionary in terms of managing these patients. So we have a lot of protocols that we've developed internally where there has to be screening that needs to happen. So every single patient that walks in through the front door has to be screened, basically for symptoms that trigger in terms of if where they need to be managed. And you need to have your cancer center be able to accommodate patients with COVID in order to get their treatments, because you can't stop treatment just because they have COVID. So I think that having kind of this divide in terms of how to manage patients up front, and then have screening procedures. So Also, even patients who have a procedure scheduled, they actually have to go get screened 24 to 48 hours before for COVID, and then they are able to get their procedure done. Could be a surgery, could be a line placement, which we know is very, very important for getting treatment started. And then the other aspect is basically having, you know, appropriate social distancing in your clinic. So, you know, getting creative in terms of how to do that, you know, taking spaces and management for all the staff on a regular basis. And protecting the staff is very important. So nurses have to wear face shields, they have to wear masks, you know, they're already wearing PPE. So every single provider who's patient facing, they're wearing masks and face shields. And there's appropriate cleaning after every single patient that is seen in a chair. So, you know, having those measures also protects the employees, and then also makes the patient safe, that it's great, it's safe to go to the institution.
No, I think, you know, following similar suits, I think, you know, everything's been almost standardized to some extent. We've seen major academic institutions and also community hospitals follow these same guidelines coming from CDC and other institutions. So, you know, the screening piece, you know, from an ambulatory center is very different than inpatient, right? Where you're not allowed to have caregivers based on your facility and also based on COVID risk. You're having reduced amounts of people come in contact, social distancing, masking, right? All important pieces of the puzzle as well. I think it's been, you know, in rather a jovial manner and also a very unfortunate circumstance, we've had to implement those practice sites in the outpatient setting as well. You know, having single site entrances for both staff and then another site for the patient, really making sure those are staffed appropriately. How do you do that, right? So a staffing adjustment needs to be made, addressing your temperature, addressing the right questions, travel questions if there are pertinent issues for bans, maybe from certain states. So I think, you know, that type of workflow in the ambulatory setting has been very different, you know, because we're used to actually bringing caregivers in. So how do you talk to, you know, that dad or mom who may have their kid with them? You may not be able to do that. You know, how do you actually have to address them coming in with a caregiver who may be their interpreter, right? These are all, you know, significant changes that have occurred in the facility and also the level of care across the country. So I think those checkpoints have prevented issues occurring, but also they've maximized care models as well. So I think those are points across the country we've been doing as well. And really adding to that, we've talked about staffing, but also for our patients, you know, one of the things that did come up early on was when we're looking at these changes for COVID, we looked at staff, we looked at other models of care. The one thing that we all do, you know, for cancer centers, based on our level or our experience and site and capacity, has been clinical trials. So, you know, have you seen any impact on clinical trials? If so, can you kind of talk a little bit about that, what that means to what clinical trials may be in 3 months from now, 6 months from now, versus what just happened with COVID as well?
Yeah, so clinical trials, obviously we had pause in terms of opening up new clinical trials, but we had to continue the ones that were open. And if there was any new ones that we were looking to open up, they would have to go through a pathway where, you know, other trials would go through the same pathway where there's an unmet need and there's no treatments, and this is an urgent trial to open where there's a significant benefit for our patients that we're serving. So we did have an avenue for that. So, but I think that enrollment and opening up new clinical trials has slowed down significantly. But, you know, we've seen also an increase in COVID-related clinical trials, especially with anti-neoplastics and biologics, and a lot of even tyrosine kinase inhibitors that are being studied in COVID. So I think that it kind of gives a little bit of assurance that maybe the drugs that we're giving for cancer actually also work for COVID. I mean, so I think that there's so much that is being done and changing rapidly. So really interesting to see that happening. I mean, recently NIH announced that they're doing a trial with baricitinib, a JAK inhibitor, with remdesivir, a combination of drugs. So I think it's really interesting, and I think that's the future that we're going to be seeing, where, there's going to be some of these drugs that kind of overflow from oncology to COVID, and also I think that also shows the importance of having an oncologist or a hematologist on a COVID team, because I think historically it's been kind of a treatment niche with ID, and then we've seen a significant multidisciplinary approach in our institution where we have pulmonary, rheumatology, oncology, and ID kind of doing this in a collaboration, which really innovates how you actually manage and treat this disease.
And I think you brought about some interesting points about the fact that with oncology, we saw this almost open bloom of any drug therapy which has anti-inflammatory activity really being addressed. So we've seen the tocilizumab IL-6 studies pop up, and that's really been associated with CAR T. If you're doing CAR T, you're using that for CRS or cytokine release syndrome. We saw, if you talk about the other therapy, the JAK inhibitor, that, and again, immunomodulatory affecting the actual reduced cytokine expression, which we're seeing, especially as those viral numbers drop down, an increase in those type of side effects. Very interesting, some of the work that's being done at Washington University, WashU in St. Louis, studying about 3 different chemotherapy agents just in this response as well. So I think that's been a huge change. Hundreds of trials popping up, maybe combinations, single agents. The recent DEX study also being shown to be effective as well. Some other drug therapies showing not to be effective, if not harmful, in addition to it. So I think we've seen a lot too. I think the one thing that we've been really seeing from a larger standpoint has been clinical trial access. I think what you're talking about in regards to clinical trials, those numbers dropped for a period of time. But I think we've also kind of reinvigorated a discussion of how to deliver clinical trials, and that really to the community access standpoint as well. Having those drugs delivered directly from a specialty pharmacy, specifically for oral drugs, has also been seen as well in these accomplishments of change too. So I think there'll be some good motivations from this as we kind of peer through some agency laws or guidelines, as we call it. But I think across the board, we've seen a large growth in this. Bhavesh, thank you so much for your input on clinical trials and also these discussions on what the institutional barriers had at your facility. One other form of that, looking at the multidisciplinary team you remarked on, and also discussing those implemented guidelines for your team members and also patients as well, has really been the impact on access. Really, the access to care discussion has always been a big input perspective when it comes to COVID, especially in cancer care. What are some perspectives when you're thinking about it from a provider, a lab, and a pharmacy? And one thing really to kind of hit on, which is always something we talk about in cancer care delivery, is delays in diagnosis and screening. So what have you seen, and also has there been anything or discussions you've heard from rumblings from CMS on this too?
Yeah, I think it's a great question. How do you get a patient into treatment and then maintain that patient on the treatment? I think one of the challenges that we had seen was that patients are being told that they need to stay home, and then they have to have these labs done in order to assess for toxicities. They have to have things that procedures that need to be done. So it's all this mixed message they get. So I think we have to get really creative, and from a lab perspective, we're thinking, can we do home draws? So partnering with a home infusion company or home draw company, where you can send a nurse into the patient's home to draw the labs. But I think you have to understand that not all companies will be able to do the complex labs that you need to do. So I think you also need to make sure that you're able to partner with the right company that can actually get the labs that you need. And then the other aspect is getting that flowing into your system, your electronic medical record. So you have this, outside vendor that's doing the labs. How do you actually get that into the system? So coordinating a portal for that. And then, it may be that you can't coordinate home draws. You can't coordinate so then, like, basically working with the community partners, it could be your CACs, it could be your local laboratories like Quest, that a patient can actually go in and get their laboratory tests done. So kind of coordinating the resources that are in the community for patients to kind of not having them to come in if they don't need to, and if they can basically get that done and outside, and you can still maintain the patient on the treatment, because you can do a lot of things virtually. And I think it really kind of goes to developing this virtual health strategy in managing patients in this type of era. So I think really focusing on how many things that you can really optimize through telemedicine, and having this patient not have to come in. And I think what this plays an important role, because if you're trying to socially distant and also limit the number of patients that are coming to your institution, you're never going to be able to get 100% capacity, right, because of the social distancing that you have to do. So I think that it makes you think about ways of optimizing access by coordinating these types of unique ways of getting patients the labs that they need, the scans that they need. They don't have to come to the institution, and still be able to get the treatment that they need.
And I think that, this has been a great discussion on this, because when we're looking at integrated telehealth or teleoncology, whatever we want to use it for the coin word term, the integration has been very important. But one of the things, kind of thinking about implementation is, how do you coordinate among all members of the team? Because if you're, talking to a patient, it's a one-on-one discussion. And with telemedicine, we can always see some of those holes, or Swiss cheese model holes, develop because you didn't talk to that person in clinic who's a nurse. You didn't talk to your pathologist. You sent the order out, but that didn't get received. You had an integrated, kind of CT scan that wasn't done or performed before their visit. So, a lot of these discussions will have to change or implement workflow changes as well, because is everyone on board again? Mm-hmm. And I think that's been something that we've kind of seen, from many standpoints. The molecular pathology, I think, has been the biggest one, where you're ordering next generation sequencing tests and a few others. Well, they're not back yet. Well, I can't treat unless I have my biomarker or your fusion protein target, right? And these are all different pieces of that as well. And really going into that, it also relates to addressing screening. And screening has also been another important piece. And I think we've held off elective surgeries. In some cases, we've even seen patients, there's been a lot of discussion across the board about what happens when patients don't come to clinic. We think they have a cancer. Well, clinic is full. There may be issues. We want to get those patients in accordingly. But we have seen that discussion happen recently about what may have happened over the last few months in regards to the diagnosis of cancer, right? And that really is where we have screening involved. We have certain types of prostate cancer checks, mammograms as well, and a few others in addition to it. So that, I think, also has been affected, regardless of who's making policy adjustments, who's making recommendations to continue on this or hold off. I think that's going to be a big pivot for many of us when we see those numbers drop. But then they're going to come back up again, and they may actually, unfortunately, come up to a higher degree of staging, which is not what we want for early onset screening, I think.
Yeah, I think it's going to be really important to make patients feel comfortable to go and get that screening. I know that CMS has actually been pretty vocal to have patients go in and see their providers, and saying that it's okay to actually do that. Even, recently our governor actually was at one of the institutions, and he was talking about how, it's really important to actually go in, and it's safe to go into to see your provider, and in not having to have these late stages of patient diagnosis in the near future. So I do think that, we need to do some more education around why it's safe to go to an institution where we have these robust cleaning procedures in between patient visits. We have all these PPE that we use in seeing every single patient. We're limiting how many visitors a patient has that comes in. We have testing that happens for every single patient who's admitted to the hospital, and who's actually getting a procedure done. So really kind of, this is probably the safest thing that you can do, versus letting your disease kind of, take the course of it. It's going to be much more severe.
That's great discussion already about, the role of COVID, and also the role of guideline implementation as well, with the COVID crisis and pandemic. One of the things that really has popped up is we've been talking a lot about inpatient discussions and outpatient ambulatory infusions. However, we know that, oncolytics are not just one. It's not just IV, it's also oral. So we have a multitude of different types of therapies or combinations in these cases too, being treated with patients. So one thing I know you've done a great job on this over the years, really addressing practice development and also managing patients. But what has your practice changed, or what have you done to change the current treatment or administration of therapies in these cases for treating and managing patients on oncolytics? And if you can just give me a consortium of what you're doing to really maintain those patients, to make sure they're being followed up correctly or even managed correctly from the start. Very broad question, but I'll let you take it from here.
Yeah, I think what we've seen is that actually there's increase in utilization of oral agents, and before the provider had option of doing oral or IV, but now it's basically looking to see why wouldn't the oral be an option, and also looking at ways of optimization of treatment by limiting the patient's exposure or footprint to the institution if they don't have to. But I think it's important to note that, putting a patient on an oral drug also has risks, right? Because you have adherence, you have toxicities that need to be managed. And we know there's a lot of data that basically talk about how patients initiate therapy, but within 30 days, they actually are off their therapy because of so many different reasons. So I think that it's definitely a challenge that we would face. But I think having a specialty pharmacy, having a robust telehealth model, is really, really important in actually managing these patients on oral oncolytics, especially in this era. So I think that what we had done, one, was actually develop a lot of our education online that we can push out to patients. So because we're not going to be able to give them a piece of paper that they can go home on and they can read. So, we started to develop these these videos for different drugs that we can push out for education for patients that they can review. Of course, it becomes challenging when you have patients who speak multiple different languages. So, we have to kind of limit in terms of what we can really create with the resources that we have. But that was actually key. And the other thing that we noticed was that we would actually have a higher show rate for patients when we had a telemedicine visit versus a live visit. Because it was done in the convenience of their home. They actually had their medication with them, because sometimes what happens is that you have patients you tell them to bring the medication and they forget, or they don't actually. They're supposed to bring all their medications and they bring one or two, and so it actually became a little bit more efficient, where we had a higher show rate and we were able to do more with the patient because they were at home. They had access to everything. So I think that there was definitely these benefits that we were seeing. And then of course, the lab coordination that we were able to do. We would identify, what's the closest community health center, what's the closest place where they can get their labs drawn so they don't have to come back. And patients love the fact that they were actually having this facilitation of things that where they didn't have to go out of their way to get their care. Especially when they're concerned. I mean, you have an elderly patient who's in their 70s and he's on an immunosuppressant, and it have to take 2 buses just to get to your clinic. So I think that becoming more virtually, developing a robust virtual care model, I think it really helped. And of course, providers were also struggling in the beginning, but I think that they kind of adopted to this. And as you have noticed, many of the payers also changed their reimbursement to actually facilitate a higher reimbursement for telemedicine visits versus what they were historically were. Of course, the concern is what's going to happen once the pandemic is over. Are the payers going to actually revert back to the initial model? And that may actually be challenging for providers to actually go back to face-to-face visits. So I think there's a lot that we need to think about.
No, I think looking through it, like you talked a little bit about the oral discussion, and I thought what you just remarked on is what we did even before COVID, but it's the fact that the convenience to a patient, has been important. And I think, when we're doing, for example, reviewing oral oncolytics, looking at drug interactions, preventing drug waste, because you can refill a prescription, but the patient may be on 3 or 4 drug therapies, which actually cause an increase of toxicity. Making sure they're actually at home or with a caregiver, addressing those stipulations for drug interactions, I think is much better than that old model of bring in your drug. I'm going to look through all of your drug. It's a typical type of situation we've seen for many years. But when the patient's there with maybe the daughter or husband or, again, wife in these cases or partner, you go through it, they're right there. They're addressing it with you. And I think we've seen a better improvement. In fact, we enforce that more than bringing their drugs in. They're at home, simple, at their convenience. That's been the best remark on those things. And that's been a huge change over the years from that model. But I think also the effect of, do we go back and do we actually go back to normal traditional routine of clinic? I think that's a great question on what that means to our practice. I think we never will lose telehealth, right? We've been pushing for this for over 5-10 years in regards to this. Now it's on. I think the question will be, will you be paid as well? So how is that going to affect us? Will it be the same after the pandemic ends, right? Because there'll be a lot of discussion on that. But also, how does that integrate into that model too?
Yeah, I think it's going to be so beneficial for pharmacists because, we've historically always been involved with telemedicine, but which just haven't been able to bill for it. And having that, avenue for billing for a telemedicine visit as a pharmacist, which we were already doing. So I think it really, helps us in the future.
Listening to your discussion on telemedicine, integration of newer models of care, also opening up different payment models here as well, we're really on another level of care models. And I think that is going to be telehealth implementation in oncology. One of the things that we've seen, and Bhavesh, really, you've been leading this, I know I've been discussing transition of care management as well at my facility, but you really have been leading a lot of these forefront discussions in telemedicine at your facility. One of the things is, what strategies are you developing to really continue the use of telemedicine at your facility? And also, what reimbursement are you using? And also, if there's one thing that you could say to CMS, if they go, Bhavesh, we are looking for you to really guide us into oncology practice management because of the cost of care of oncology, what would you like to see there for telehealth in the future so we can continue these models of care?
Yeah, I think one thing I've heard, CMS, specifically Seema Verma, has been very vocal about actually pushing the Trump administration to continue to cover telehealth at the same rate as as they are currently doing right now, once the pandemic is over. So I think that really kind of shows the biggest payer in the entire country is actually going to support that for telemedicine to continue with the way it is. And also, I've heard a lot of the Blue Cross plans across the country. They've also put out a public statement, saying that they would continue to cover telemedicine at the same rate that they have been currently. So I think that really incentivizes providers to be more efficient. And from the way I think about it, that actually provides more access for patients because, imagine how many patients you can see in a telemedicine visit versus a face-to-face visit. So I think of course, you're never going to be able to get rid of the face-to-face visits at all completely. So I think you need to have maybe like a 50% face-to-face and a 50% telemedicine visit. So I think that, you would be able to create more access for patients who actually need it, who really urgently need to see a provider. And then there's patients who just need this maintenance of seeing a provider. So I think that really will make the healthcare system more accessible for patients. But I think we need payer support to do that. And from a pharmacist perspective, I do think that the billing is important. And a lot of pharmacists actually struggle here where, we've been billing for pharmacy services for over 4 years now. And a lot of institutions across the West Coast, Midwest, they have a pretty robust billing model. And of course, providers, I mean, institutions are sometimes confused the fact that you have to have a provider status in order to bill, but it's not true. Obviously you do want to have an advanced practitioner model in order to actually function as a provider, but you don't need to have that in order to bill for it. So definitely, working, the ASHP has a lot of guidelines and recommendations on how to actually develop this service in your institution. We reviewed a lot of those, and we also talked with a lot of institutions who had been doing this for years before we did that. And, based on the number of patients, number of pharmacists that we have across, we do about 20,000 plus visits annually, which of course continues to grow. With telemedicine, I think we're doing double the amount of visits. So imagine the access that we're creating for our patients by having this telemedicine and not having the face-to-face for every single patient. So it'll be really interesting to also see the outcomes that we're able to drive by having this increased access for patients, especially in the therapies that we're using. I think that there is a higher failure rate, higher fall off rate, higher toxicities that we see, and of course, cost is a huge barrier. So I think that there's a lot of things that we will see change, and maybe this will actually help us get provider status because we're already functioning at that level.
Right. And I think, the one thing you've already talked about is, discussion on prescriber status versus institutional billing, right? That's been really kind of been seen as this whole detriment to add on to that bill for the patient. But the discussions on, we're doing it already, we just really haven't been charging for it correctly. I think if you went to a majority of the sites across the country which are already doing it, they're not charging for it, or it's not even considered a billable service, even though you have charge codes, you have certain different, TCM, transition of care management. That's built into CMS. You can do that for every single discharge patient. It's just making sure that you have a team ready to kind of develop that process and also make sure they're maintained at that point as well. Because we know that if we're not doing those checks, whether it's a review of a patient's medication, whether it's an educational piece, an adherence check, those patients tend to fall off the system, right? And that's, I think, going to be one of the things for telehealth. If telehealth is not, for example, pushing the patient to be seen, getting their labs checked before a visit, that becomes an issue for compliance or adherence. And I think that's always been a discussion about taking care of the patient, really that model of management or that role of management in therapy treatment. So I think from that standpoint, the layer of how we integrate these will be important, but also will affect patient care in the future as well. But the other thing is, if it's an uncompensated care model, how do you maintain that for the future, especially after COVID, what we're going to do there? So that's really leads up to our next question from what you're talking about and really kind of going through is the pharmacist role here, right, in managing therapy. We've touched upon it throughout the course of our discussion today, addressing how we implement guidelines, implement biosimilars, utilizing therapies, and also utilizing care from outpatient or inpatient delivery mode. You also kind of address as well, specialty pharmacy roles, and also home infusion, right? Some key important pieces, as well as some of the billing models there as well. One thing or two things that we've actually also addressed is how to communicate. We're communicating with our physicians, our team members, or other care members across the continuum of healthcare, the interprofessional based discipline. When we're taking a look at management of therapy in these cases, how are we doing that from a telemedicine visit versus a face-to-face visit? So really, my question is, and this really kind of goes back both back and forth in these discussions, when we're taking a look at monitoring of therapy, what are we doing to make those adjustments made? How do we relate that to our specialty pharmacy? If we're looking at adverse events, is that something we have to delineate with a telemedicine visit versus an office visit? And also, have we kind of changed our dynamics for okay to treat parameters, our monitoring parameters in these patients, and also other concerns for lab access as well?
Yeah, I think one thing that, would really help is actually having a more robust virtual platform. I think that we're basically limited to what we have with Zoom and, there's doximetry and a lot of virtual platforms. And I think having a more robust platform where we can have a team-based approach that can kind of incorporate a lot of the things that we need to manage a patient holistically in terms of their dosing, in terms of toxicities, in terms of laboratory, in terms of referrals to other specialties. So I think having a virtual platform that can kind of incorporate all of those things would be really, really helpful. And I think having a pharmacist on this team and taking care of the telemedicine visits, it really helps build the practice even more, because we see more and more oral therapies coming out, and I think that there is a lot of oversight that needs to happen over adherence in terms of toxicities, new therapies, dose adjustments, drug interactions, all these things that need to happen on a regular basis. And I think this can be really, really captured by telemedicine and developing a robust model that kind of incorporates this team-based approach with a better virtual platform. And I really challenge somebody to actually put together something that can really, really, maybe integrate with Epic, because I think that's probably the biggest electronic medical record that folks use across the country. And really be able to even pull in an interpreter when you need them, and have a virtual waiting room that you can have a patient in. You can have co-visits with another provider or nurse or pharmacist. So I think that really need to kind of go out of the box and think about ways that we can do this in the virtual platform.
So the one thing, Bhavesh, I really like what you're saying, because I've often envisioned this too, is if we have a platform which utilizes a integrated professional care model, it would almost be like looking at an Outlook calendar. You have your physician team members seeing the patient at this point in time, but maybe beforehand, MA actually reviews information. You have your nurse for any other conditions for a checklist. You have your physician with patient-based care and evaluation there. You have your pharmacist if it's a therapeutic option or care model, reinforce education, and maybe have another telemedicine follow-up visit, nutrition, et cetera, et cetera. So maybe having a delineated workflow where that hour visit is actually partitioned. And now everyone is on that schedule, right? And I think that's what we're looking for in terms of progress, because that only helps us in terms of understanding dosing, adjustments, looking at supportive care medications to keep that patient on treatment, right? And also address any other issues for adherence barriers, for example, copays. Well, I just got this prescription from mail order pharmacy, and you may not be able to capture that because of telemedicine on that visit. So I think there's some issues there which can be integrated across the board, where we're working with a virtual partner here. Whoever's developing this EMR Doximity as well, Epic has their own, and I think there'll be some changes on this quickly as we're maneuvering through this process. But I think that will be one piece. But I also think the role of digital medicine, for example, we're talking about adherence and other models, do we have an adherence check? What's their blood pressure? What's everything else? We've seen numerous technologies come up from innovation sides that also address this too, whether a watch or another area as well. So I think there's a lot of collaboration there that can occur. I think it would be great, as well as what we talked about with the virtual patient education piece. Those, maybe limiting in some extent, but I think there's a role there, as well as education models for workflows with providers and also manufacturers as well. And so, let me actually just follow up and really I'll give you the last question of the day so you can kind of hit it out of the ballpark here. One of the things that we've seen is with discussion of COVID, discussion of institutional models and also organizational models of COVID treatments and also clinical trials. One thing we've also seen is utilization of the cancer registry. Really, the ASCO COVID-19 cancer registry has really discussed some important roles here and also models for treatment when we actually learn more about the patient. So can you discuss the new ASCO COVID-19 cancer registry and also just provide a little commentary about the implications of this registry too, if you have more information on it as well?
Yeah, sure. So it was really interesting, ASCO being virtual, the biggest conference in oncology. But, I think they had a lot of great things and presented. So the two abstracts that kind of caught my eye was, one was about 1,000 patient registry that was presented, multiple different malignancies in one registry, where they were looking to see if there was risk factors that you can identify that basically increase the risk of having worsening of death or outcomes from COVID and having that risk factor. So whether it be performance status, whether it be receiving a specific chemotherapy regimen, whether it be specific tumor that you have, a lot of different factors, age, of course, and you know, I think there was interesting results that they had kind of put out there at ASCO. And the other abstract was also a registry specifically on thoracic malignancies. And it was about 400 plus patients that they were looking to see also, again, the regimen, age, smoking history, things like that, were basically impacting, you know, the outcomes with COVID and those specific risk factors. And you know, I think, of course, we don't have enough numbers to actually make conclusions. But they did identify that, you know, patients who are basically progressing on their cancer or were elderly or had actually a smoking history, and they're 3 months within receiving a combination of immunotherapy and chemotherapy, they probably had a higher, you know, increased risk of dying from the virus. So I think, you know, my perspective on this is that, you know, of course, it's too early to kind of make assessments of, you know, specific malignancies, specific agents that maybe, you know, kind of impacting the outcome of COVID and those risk factors specifically. And the other thing is that we're looking at this data at a much earlier time point where we didn't actually know how to manage these patients. You know, I think that when you look at some of the publicly available statements or from states with second surge, you know, we've seen that actually not as many patients actually end up in the ICU, and a lot of the cases are not as severe as they were before. So I think we have the treatment paradigm for COVID is really evolving fast. I mean, we have remdesivir that has, you know, emergency use authorization. There was data that was published with dexamethasone that came out recently with patients who are intubated. And you know, there is combinations. Now we know exactly when to start treatments with biologics on patients. So we have a lot of things that have changed the practice of COVID, treatment of COVID. And I think that, you know, we may be assessing the impact a little bit too early, and it might be different what we see now if you look at a registry for those 1,000 patients. So I think the evidence is evolving, and I don't know if I would actually really kind of associate, yes, you have lung cancer, you have a higher, you know, chance of having risk of dying from COVID than you have with other malignancies and this cancer treatment. I think, you know, any COVID patient should be treated with, you know, the risks that they would have across the board. So,
and I think, you know, the discussion continues, right? We didn't have enough testing 3 months ago. Now we have access to testing. So that has really increased the number of patients. We've also noticed that the patients who would come in would probably be sicker than earlier patients who may have mild symptoms. So I think there may even be more cross categories as we kind of see. Patients may actually have a mild infection with COVID while also having cancer treatment, or maybe a cancer survivor as well. You know, what are those implications? The immunotherapy question, I think we're all learning about this. I'm actually very interested in this discussion as well, because does immunotherapy augment our immune system to fight off the virus, or does it lessen it? And I think that's been a constant discussion early on, with lots of hypotheses coming up, but no real determinant on these discussions too. So I think the registry hopefully provides more information as it goes on, and also as our testing gets better and our also understanding of therapies evolves with this, with the evidence of new therapies coming into the clinical trial arena. I think hopefully that will provide a better understanding of treatment. And I think the dexamethasone discussion just recently coming out, no surprise, but I do think it kind of shows you the value of clinical trial data really coming to light in these patient populations as well. Great answer. Thank you, Bhavesh.
Thank you. So before we conclude, you know, Ali, would you like to share any final thoughts?
Bhavesh, thank you so much. I think this has been a great discussion across the board. I think, looking towards COVID, I think we're in this for the long haul now. It's not just a short bump. I think really seeing institutions move quicker than normal, whether it's our own institutions or health systems, looking at government-based regulations with CMS and payers, as well as guideline organizations and also guideline suggestions from NCCN and ASCO. I think we've really moved quickly for patients in regards to implementing the best care, the most appropriate care, bevied with the utilization of tele-oncology, as I'm going to call it from now on, Pavesh. We're going to coin that phrase. So I think the telemedicine, tele-oncology piece are all integrated together. And so, looking forward from COVID, right now in this crisis that we're in this pandemic, I think we're going to have to continue to look at the patients and address the patients appropriately. As pharmacists, continue our role in management, regardless if it's face-to-face or through telemedicine services, and also ensuring appropriate care by maintaining those patients in either setting, inpatient or outpatient, to ensure adherence and also actually develop the best or appropriate outcomes as well based on their therapy too.
Thank you, Dr. McBride. And, just my final thought is, it's amazing what, you take out of something that has taken over significant portion of everyone's life, I think, but it has made us more efficient. I feel like it has made us think about things that we weren't before in an accelerated rate. I mean, we're definitely taking cost as a big equation into how we operate in terms of should we be adopting biosimilars aggressively because of the financial situation of the healthcare system, the institution, the payers, also basically getting telemedicine up and running. As we had talked about how it took us years and for pushing for telemedicine, and because of COVID, we're actually doing telemedicine probably 90% of the time for our patients. I think for oncology, we haven't seen a big change in the way we practice in terms of the volume of things that we're doing. We still, cancer has to be treated. So I think that, but we definitely have to evolve in terms of how we manage it and how we make our patients feel comfortable with so much data coming out across different spectrum of diseases and COVID. I think it's really important to educate our patients, to continue with registries, to put more information out for providers so they can make more informed clinical optimal decisions for managing patients with COVID and malignancy. And I just want to thank you and to our viewers and audience. We hope you found this Pharmacy Times webcast to be rich and informative.